All right, I'm gonna go ahead and get started. I have more slides than typically I like. My mentor out in Boston told me you should anticipate 2 to 3 minutes per slide, and I overshot. So I may go a little quickly. If I'm going too fast, please let me know. I'm certainly happy to slow down. The conflict of interest disclosures talk about, do you personally have any relationship with outside entities? And within the state, actually all the relationships are between the state and the outside entities. So I just threw this up there that I'm the local PI on just a registry, which is an observational study of a PAH-specific medication. And I will talk about off-label use of drugs, but not any particular drugs, just drugs within a certain within a certain disease state. So where are we going today? I want to talk about the causes of elevated pulmonary artery pressures, and particularly talk about the WHO groups. Notice that I've sort of separated out pulmonary arterial hypertension from elevated PA pressures, and that's because elevated PA pressures are merely a phenomenon and not a particular diagnosis. You actually have to go through an algorithm to work up the etiology of them to really understand what the diagnosis is. And we'll talk about the workup of suspected pulmonary arteriopathy, that is, WHO group 1 or pulmonary arterial hypertension. And if you take away 2 things from this lecture, the 2 things I would want you to take away is that right heart catheterization is the last thing that you do. Pulmonary arterial hypertension is a diagnosis of exclusion, and you should have figured out the diagnosis in about 80 to 90% of the patients before you even get to right heart cath. And you'll see the diagnostic algorithm currently recommended in just a minute. The other thing is, if you want a right heart catheterization, I would ask that y'all talk to either me or to the pulmonary service first. At the national meetings, like the American Thoracic Society meeting, in the sort of give and take sessions with some of the experts, they estimate that they repeat about 80% of the right heart catheterizations on the outside referrals. And it's because the data doesn't quite make sense to them, or they didn't do a particular intervention like a volume challenge or something like that. And so it's better just to go ahead and send it to the person who's going to be using the data to obtain the right heart catheterization, rather than having it done and then hoping that it doesn't need to be repeated. We'll talk a little bit about the treatment on the other WHO groups, and talk more particularly about the treatment options for pulmonary arterial hypertension. So I want to start off just with a question. So a 65-year-old who smoked a pretty good bit, 55 pack years, presents with exercise intolerance. Echo shows stigmata of RV pressure overload, and the estimated pulmonary arterial systolic pressure is 58. So which of those diagnostic strategies do you think are right? Pulmonary function tests, right heart catheterization, sleep study, or ANA and rheumatoid factor? So who would say A? Who would say B? Who would say C? And who would say D? So honestly, I would we'll talk about it at the end. I would actually do pulmonary function tests because the probability of intrinsic lung disease in a long-term smoker with those sort of symptoms seems likely, but you'll see sort of in just a second. So how is pulmonary hypertension classified? It used to be called primary pulmonary hypertension and secondary pulmonary hypertension, but that didn't really work because the primary pulmonary hypertension had a particular histopathology that it shared with some of the secondary phenomenons, but didn't share with other of the secondary phenomenons. And so it was really sort of an unworkable diagnostic classification, primary versus secondary pulmonary hypertension. So what do they do? They did the typical thing that academics do. They found a nice place to have a conference, and there have been a total of the 5th World Symposium is coming up. And they've been in some pretty nice places around the world, and people traveled to them. And they sat down and spent some time talking about a logical framework and came up with the original WHO 5 classifications. And they come back to meet on a fairly regular basis, again in pretty nice places. And they're now going to have the 5th World Symposium in Nice in February. So what did they do? This is the strategy that they currently propose, which group 1 is pulmonary arterial hypertension. And we'll talk a little bit about this, and you can see there's a bunch of different associated conditions that are in there with WHO group 1. Group 2 is easiest to think of anything that causes left atrial hypertension. Systolic or diastolic dysfunction, valvular disease, LV outflow tract issues, just anything that can increase your left atrial pressure fits into WHO Group 2. WHO Group 3 is any intrinsic lung disease, such as COPD or ILD. Group 4 is chronic thromboembolic pulmonary hypertension. And then Group 5 is just sort of the wastebasket, everything else that doesn't really fit neatly into these other groups. The way they did this actually made sense when they did it. They were most interested in what used to be called primary pulmonary hypertension, or all of its cousins. And so they were interested in this arteriopathy of the pulmonary circulation. So this is a cartoon of the right atrium, right ventricle, pulmonary arteries, alveolar capillary unit, left atrium, left ventricle, and going out to the body. So this is what they were most interested in. So of course it got number 1. And then they just anatomically started off on the left side of the circulation and backed up. WHO Group 2 with left atrial hypertension, WHO Group 3, intrinsic lung disease, WHO Group 4, you're back in the pulmonary artery, and then Group 5 just was in everything else. And if you just sort of remember that schematic, remembering which groups there are is pretty easy. The groups are different in terms of their pathogenesis, and I'm just going to touch briefly right now on it. We'll talk in a little bit more detail as we go through the different groups. Group 1 is an endothelial cell disorder. The endothelial cells lose the typical characteristics of endothelial cells. They lose contact inhibition, and they start doing things like expressing tissue factor, which makes it so that they can kind of stack up. As they stack up, the media, the muscular layer of the pulmonary arteries, starts to proliferate and become thicker, and then blood goes through that. It sort of slows down, and as it slows down, you see in situ thrombosis. Group 2, like I said, is anything that causes left atrial hypertension. People frequently refer to it as post-capillary pulmonary hypertension, but there's some subtleties about that we'll talk about in a little while. Group 3 is the loss of functional alveolar capillary units, and you can lose that through destruction, or they just may not be functional, or you may be on top of Mount Everest because your oxygen levels get low there. Group 4, chronic thromboembolic pulmonary hypertension. It may be a misnomer, and you'll see we'll talk about that in just a little while. And like I said, Group 5 is everything else. So when I see pulmonary hypertension patients in clinic, I basically have 2 questions that are going on in the back of my mind, and I'm trying to sort it out. The first question I'm asking to myself is, what group are they in? And you can usually sort this out by just simple history and physical and sort of basic non-invasive tests. You should keep in mind the overwhelming probability of when you see patients in clinic with pulmonary hypertension, the overwhelming probability is they're not in Group 1. The population prevalence of pulmonary arterial hypertension is very low, on the order of about 50 to 100 per million people. So area code 318, it's about 1.5 million people in North Louisiana, and so you're looking at maybe 75, maybe 100, 125 people in that catchment area. If you can figure it out by history, physical, and some basic workup, then you may be able to avoid right heart catheterization. So the first question, which group are they in? The second question, if they're in Group 1, how severe are they? Because that will inform how you're going to go about treating the patients. So this is from the most recent guidelines from the European Society of Cardiology and European Respiratory Society, which is pretty similar to JACC and ATS and all the other current recommendations. Basically, if you have somebody who's dyspneic and you can't come up immediately with another reason for them to have those signs and symptoms of pulmonary hypertension, then you get an echocardiogram. And there are a bunch of different echo findings that can suggest pulmonary hypertension, and we're not trying to become echocardiographers today, so I'm going to kind of leave alone Table 8. But if they have a high probability or an intermediate probability that they indeed have pulmonary hypertension, then you should start thinking about left heart disease, lung disease, and just do those basic tests like pulmonary function test, a chest radiograph, maybe a high-res CT, and maybe arterial blood gases. And if you found that, in fact, they do have left heart disease, or they have significant lung disease that explains the elevations in the PA pressures, you just treat the underlying disease. You don't necessarily have to do anything else. If they either don't have that, or they have signs of severe right heart failure, then you see that in each of these algorithms, or pathways in the algorithm, you end up referring them to a pulmonary hypertension center. They suggest that before you send them to the pulmonary hypertension center, getting a VQ scan. We'll talk a little bit about that when we get into the workup of CTEPH, or chronic thromboembolic pulmonary hypertension. They're going to think about that possibility and maybe do an angiogram and a right heart cath at the same time, or do right heart cath. And if they're able to establish the diagnosis of pulmonary arterial hypertension here, you then would go down this way, do tests for these secondary diseases, and treat the underlying pulmonary arterial hypertension. So it seemed to me that case-based education is always the easiest way to think about things. And this is one of our patients that actually we saw some time ago and continues to do well, so well in fact that he often doesn't show up to clinic. He's a 32-year-old African-American gentleman. He presented with progressive dyspnea and exertion. His past medical history is pretty benign. He had some hypertension, which was controlled with calcium channel blockers. His social history, never been a drug abuser, wasn't a smoker, had never taken diet medications. His family history was pretty unremarkable. No one died of early heart disease or pulmonary arterial hypertension. No one had any blood clots. And he didn't, on review of systems, he didn't have any rheumatological things like Raynaud's or skin changes or malar rashes or anything like that. And didn't really have any anginal symptoms. It was dyspnea, not chest heaviness or anything. And his Epworth sleepiness scale score was entirely normal, so he didn't really have any symptoms of sleep apnea. On his exam, we do 6-minute walk tests in clinic, so his vitals were pretty unremarkable, except on 6-minute walk tests, he only did about 300 meters and desaturated to 91%. A healthy adult typically should be able to do at least 360 meters, and men, depending on their height, even a little bit further. And they certainly shouldn't desaturate with exercise. And then on his exam, you see that he had several findings that were consistent with RV pressure and volume overload. You could feel his RV sort of pushing in the parasternal area. He had accentuation of the splitting of S2 with a loud P2 component, and had a tricuspid regurgitation murmur. He didn't have florid right heart failure. He didn't have a big liver, and didn't have abdominal protuberance or lower extremity edema or swelling. This is his chest x-ray, and you can see the parenchyma is pretty normal. There's not like bad fibrosis or anything like that. His heart is generous and really suggestive of filling in of the aortopulmonary windows. The PAs are likely enlarged, and the RV shadow is a little bit enlarged there too. So he got an echocardiogram that suggested elevated right ventricular systolic pressure. So how do you do that? So you see, you get an echo transducer, and what you're looking at is the velocity of this jet. And they make a bunch of assumptions about size of the orifice and all this other kind of stuff. And you end up with this formula, that the delta pressure between the RA and the RV during systole is a function of the square of the tricuspid regurgitant jet times 4. There are a lot of assumptions in that, one of which is what right atrial pressure is. And it can be difficult to estimate it, especially as it goes high. And if you think about it, if you use 10 as an estimate for a normal person, a lot of people may not have had anything to eat or drink, and their RA pressure actually may be lower than that, or they may be volume overloaded a little bit and have an RA pressure that's more than that. So you can imagine plus or minus 10 to 15 points on an estimate of what their tricuspid, what their PA pressures are, is not inconsequential and not clinically insignificant. So there are other things you can also look at, and you can look to see if the RV is gargantuan, the RA is huge, whether the IVC is over-distended or it has a normal variation with respiration. So you take that composite picture and then sort of decide whether you think the person has a high probability of pulmonary hypertension. In him, the probability is pretty high. So we've got to kind of figure out, well, what group does he fall into? And when you look at that algorithm, the first thing to think about is, are they in group 3 or group 2? Group 3 is when you have intrinsic lung disease. And you should remember that an elevated pulmonary vascular resistance is entirely a normal response to hypoxia or loss of functional alveolar capillary units. When you take people to the top of Mount Everest, they get profoundly hypoxic. All the little pulmonary arterioles will clamp down trying to send blood to areas that are that have a lot of oxygen. And well, on top of Everest, none of them do. So every unit is clamped down, so resistance goes up, so pressures go up. That's just the lung trying to match blood flow to ventilation. Those hemodynamics on right heart catheterization are indistinguishable from WHO group 1. So you clearly have to make sure that they don't have enough lung disease to explain whatever their hemodynamics are before you go to right heart catheterization. The typical diseases you think about are COPD or interstitial lung disease. In this region of the country, obesity hypoventilation syndrome is certainly in the list of diagnostic possibilities. There's some studies have looked at where can you sort of not have to do an arterial blood gas, and there's some that suggest that if your venous bicarb is less than 28, that's usually consistent with a normal PCO2. So if someone's bicarb is 22, it's pretty unlikely they have elevated PCO2, though there are some exceptions to that. If they had some tubular dysfunction or other renal diseases, that may not be the case. And you may need to get direct sampling of the arterial blood to know for sure. Sleep apnea continues to be a little bit of a conundrum. If you have intermittent hypoxia, most people don't believe that you'll have a sustained increase in the pulmonary vascular resistance. And most people that have sleep apnea don't have daytime hypoxemia. They're awake as long as they don't have a concurrent alveolar hypoventilation. And as a result, most people feel like until someone has such severe sleep apnea that they have daytime hypoxemia, that OSA is not a great explanation for any underlying elevations in their pulmonary pressures. That said, they're not helping them. And so at night, when they do have their nocturnal desaturations as a consequence of their sleep apnea, it's making the RV's workload worse. And so you're going to need to treat it. You can't ignore it. But at the same time, it probably does not explain any elevations in PA pressures. So in our guy, his history was not really suggestive. He didn't have a lot of risk factors, wasn't a smoker, hadn't worked in the chicken plucking industry or anything like that. And his exam didn't show any wheezes or rowels suggesting he had something. So he went to get his lung function tested. Spirometry tests your airways, and it looks at the relationship between flow and volume. And his spirogram was entirely normal. It showed that his airways were functioning normally. His lung volumes showed that his lung compliance was normal and they weren't all scarred up or otherwise restricted. But oxygen was still having a problem getting into the arterial blood. His blood gas showed a relatively elevated AA gradient with PaO2 of 60, and his diffusion capacity was about 50% of predicted, if I'm remembering right. It's worth remembering, because this kind of stuff occasionally shows up on internal medicine boards, the mechanisms for hypoxemia. One of them is hypobaric conditions. So if you go to the top of Mount Everest, you're going to have a low PaO2. The highest point in the state of Louisiana is Driscoll Mountain, which is sort of over towards Ruston, and it's only 535 feet. If you haven't been there, it's worth going. It's about a mile walk. You don't need crampons or ropes or anything like that. You should be okay. And you park at a church, and it's a privately held land, and they will actually let you get there. Hypoventilation can cause hypoxemia. So if you paralyze somebody long enough and their CO2 rises, eventually they'll actually displace enough oxygen in the alveolus to get you to be hypoxic. But his blood gas didn't show that. Diffusion defect usually is, you'll be able to see it on imaging. There's an increased thickness to the interstitium that's limiting the gas transfer. The two remaining etiologies would be intrapulmonary or extrapulmonary shunt and VQ mismatch. And VQ mismatch really is the main reason that people get hypoxic with lung disease. But so far, we don't really have any evidence that he has any airways, alveolar, or interstitial problems. And so we're sort of still left with a vascular problem. This is a CT scan, his CT scan actually, and you don't see, these are obviously not lung windows, but typically if someone had bad fibrotic disease, there'd be enough density that would show up in the bases and you don't see it. What's impressive is this is his right atrium and this is his right ventricle, and the RV is at least the same size as the LV in that cut, and you see his pulmonary artery is probably 1.5 times the width of his aorta, and that's not normal. So he doesn't seem to have group 3. But if he did have group 3, then what would you do? Ultimately, you need to treat the underlying disease. If they have what seems to be crazy high pulmonary artery pressures or a failing right ventricle, it's worth having pulmonary CM to see if there could be 2 diseases at the same time. Occam's razor is generally correct that if there's one etiology to explain what's going on, it's the most likely explanation, but then sometimes people get struck by lightning twice. So if they have COPD, getting them on appropriate therapy. If they have ILD, getting them on appropriate therapy is appropriate. The PAH-specific medications there's some seminal work being done with the PAH medications that actually are not very promising. There are black box warnings with the PDE inhibitors and the ERAs because of worsening hypoxemia. And in this study with IPF and riociguat was actually stopped early because people on therapy were doing worse than the placebo people. And ultimately, that kind of makes sense to me because what you're doing is you're reversing the normal physiological response to hypoxia. You are causing a pulmonary arteriolar dilation. And so it's allowing blood to go to non-functional alveoli, which is basically worsening intrapulmonary shunt. And that's, in fact, what most of the studies have shown is that people get more hypoxic associated with the medication administration. So if he doesn't have group 2, group 3, might he have group 2? And this is sometimes very difficult to tease out whether they have just purely left atrial hypertension or do they have WHO group 1 disease. Echo can actually give us some hints, and as can history and physical. When you look at the people who have pulmonary arterial hypertension, they're demographically and clinically different than the people who have left atrial hypertension. That said, there's increasing overlap as we better understand PAH. The echo can also give us some hints, and we'll talk about that in just a second. In him, he had normal systolic function and no stigmata of left atrial hypertension, and we'll see what those are in just a second. So who gets group 1 versus group 2? People in WHO group 1 are typically younger. They're usually between 30 and 60 with an average age of about 44, although that's gotten older with new registries as we've started to realize that some of the stuff that we used to just chalk up to heart failure is actually pulmonary arterial hypertension. Women have it more commonly than men, some depending 2 and 3 times the rate that men do. And the risk factors for PAH, as you saw, are things like connective tissue disease, particularly scleroderma, HIV, portal hypertension. And idiopathic or familial are responsible for about half the cases, and there are risk factors present in the other half of the cases. And they don't particularly overlap with the people who have WHO group 2 disease. WHO group 2, they're usually older, they're usually male. They have things like diabetes and long-standing systemic hypertension or valvular disease or other sort of etiologies. Our guy, he's on the younger side, he's male, but that doesn't really exclude anything. And he doesn't have any clear risk factors here, but he doesn't entirely fit in this category. So you're still suspicious that maybe this is WHO group 1. I am not an echocardiographer. I don't pretend to be an echocardiographer. And this is why I like this slide so much. As you see, there are a bunch of different things you can look at in echo, and a surrogate for relaxation, and some of the other changes on echo can all give you a pretty good sensitivity and specificity for predicting left atrial hypertension. But I'm not an echocardiographer, so what I do is I just look at their left atrial size. And if the left atrial size is entirely normal, then it makes me suspicious that they don't have left atrial hypertension because its specificity is pretty good. This is an algorithm that is complicated, and I'm not going to take you through it, but you see ultimately there's a good way to end up with a diagnosis of heart failure with preserved systolic function that doesn't include invasive hemodynamics. You can look at tissue Doppler, you can look at biomarkers, you can look at the EDA changes, left atrial size, mass, LV mass index, presence of AFib, and all this stuff can come together to create a good argument that this is just heart failure with preserved ejection fraction. You don't necessarily have to go to invasive measures of it. So group 2, I would argue that it's probably the most common etiology here. In our patient, we're not yet sure. We don't have a direct measurement of LVEDP. He has at least one risk factor for heart failure with preserved ejection fraction, that is his essential hypertension. But his echo really isn't particularly suggestive. Even invasively, it can be difficult to distinguish between people who have left atrial hypertension when they have heart failure with preserved ejection fraction from the people who have PAH. And sometimes what happens is the left atrial pressure goes up, and that back pressure just pushes back into the pulmonary arterial circulation, and that makes the pressure in the pulmonary arteries go up, but their pulmonary vascular resistance is normal. It's really just the left atrial pressure pushing back. If you have long-standing left atrial hypertension, though, that can actually induce vascular remodeling. So if you have bad mitral stenosis, over time, the media get thickened and the lumen gets smaller in the pulmonary arterioles, and the resistance goes up. And we know that actually is a bad sign. If you don't do anything about their mitral valve disease, their probability of death goes up. Their risk of surgical intervention if they have an elevated pulmonary vascular resistance is higher. And if they have heart failure with preserved ejection fraction, their long-term outcomes are not entirely different from the long-term outcomes of untreated pulmonary arterial hypertension. And so these people are very concerning when your PVR is high, and it's all from left atrial hypertension. The pulmonary arterial hypertension tends to have a much higher pulmonary vascular resistance, usually a couple, threefold higher than the people with heart failure with preserved ejection fraction, and usually have a lower wedge. But there really is a lot of overlap. As the RV gets really big, it makes it so the septum is actually really stiff, and so the filling of the LV can be impaired, and that can bring the pulmonary capillary wedge pressure, the LV end diastolic pressures up. And that's actually a really bad sign for people who have pulmonary arterial hypertension. And this is one of the reasons it's so important that the person who's going to be making the clinical decisions about how best to treat the patient with pulmonary hypertension actually be present at right heart catheterization, because there's a lot of subtleties that they may want to explore while the catheter is actually in place. So our guy doesn't have group 2 and he doesn't have group 3. Well, what about group 4? He doesn't have any personal or family history of venous thromboembolism. It's interesting, people with massive PE with RV pressure overload during that acute phase, people often get worried about those people, but 95% of those people a year later will have a normal echocardiogram even without any sort of treatment of the elevated PA pressures. In our guy, his VQ scan and his CT pulmonary angiogram were negative, so probably not group 4. A couple of comments on group 4. If you want to be cool, call it CTEPH. Chronic thromboembolic pulmonary hypertension. It actually may well also be an endothelial cell disorder. The endothelial cells act a lot like fibroblasts. They will actually allow platelets to aggregate, and if you put them in culture, they express a lot of the receptors that fibroblasts actually do. And there's this lack of clinical correlation between massive PE and the development long-term of pulmonary hypertension. CTEPH is a surgical disease in the right hands. In about 60% of people, they are operative candidates. The perioperative mortality in experienced centers is about that of bypass, somewhere between 2 and 4%, kind of depending on what group of patients that you're operating on. That requires, though, that you're doing at least 10 pulmonary endarterectomies per year. And I don't know that anybody in the state of Louisiana is doing that. The most famous center is UC San Diego. They have a very high volume center, and if someone can afford to go to UCSD, that's probably where I would send them. Their survival is better with an operation. You see that at 3-year survival, if you operate on them, 89% of them are alive at 3 years versus 70% who are not operated on in the same registry. Not everybody is entirely cured of their pulmonary hypertension. About 20% of the people will be put on pulmonary arterial hypertension meds, the pulmonary vasodilators. 80% of them are cured of their disease. They need long-term anticoagulation. And if they survive the surgery, they don't tend to die of CTEPH. Some of these people are older and have other concurrent diseases. And so if they survive their surgery and sort of get out of the perioperative phase, they're sort of settled down, it's more likely that something other than CTEPH will kill them than the CTEPH itself. There's some new technologies out there. One of them is balloon angioplasty, which makes it sound like you go out and you just overstretch the pulmonary arteries. And that's not exactly what you're doing. When you look at I hesitate to call them clots, when you look at the fibrous stuff that's lining the pulmonary arteries, they tend to actually form these webs. And that web causes sort of slowing down of the blood and increasing the resistance to blood flow. So what they're really doing is going out with these relatively small balloons and just sort of breaking up the webs and creating a larger, more central passage for the blood to go through. In the short term, it improves hemodynamics, symptoms, and functional capacity as compared to baseline, but there aren't any randomized clinical trials yet with balloon angioplasty. The people who make riociguat like to say, well, we're the only drug you can use in CTEPH, and that's not really effective. It's the only drug that's undergone FDA scrutiny. There are publications with other medications in CTEPH. There are very few randomized clinical trials with very sort of short-term follow-up in those trials. Their hemodynamics are substantially improved across the board with each of the classes that have been examined. And in the registries, in the people who are not operated on in the larger, longer-term registries, the one-year survival for these people who were deemed so sick they couldn't be operated on, their survival is actually pretty decent at 88%. One final comment about CTEPH. If you look at that algorithm, they say the diagnostic algorithm I showed you, they say do a high-resolution CT and then do a VQ scan. Honestly, I do both a low-resolution CT pulmonary angiogram and the VQ scan as part of the workup. If somebody has such bad ILD that they're getting pulmonary hypertension, I should be able to see it on a standard resolution CT. And I think of the two studies as complementary. VQ scan is probably better for peripheral disease, and the CT pulmonary angiogram is better for more proximal disease. And you see here, there's this huge clot sort of sitting down here, and it's not, this is sort of the shadow of the heart. It's really hard to see that there's this big perfusion deficit, and it's because it's been recannulized in a lot of places. And so I think of them as complementary studies. So where are we with our guy? Well, he certainly had signs and symptoms of pulmonary hypertension with clinical exam findings consistent with RV volume pressure overload. His echo actually was a high probability of having pulmonary hypertension, and we couldn't find any evidence of left heart disease or lung disease by either exam or testing. So we have not confirmed it, and he had, as we said, a VQ scan that didn't show anything. And so now we're to here. So now it's time to do the right heart catheterization, see if he meets the criteria for pulmonary arterial hypertension. So just to remember, this says Swan-Ganz. Do you know what the difference between Swan-Ganz and right heart catheterization is? Anybody know? It's like $700. If I put in a Swan-Ganz, I could pay like $80. If I do a right heart catheterization, I get like $100. It's just a huge pay difference. Swan-Ganz is put in at the bedside, theoretically, to do monitoring, and right heart catheterization is a diagnostic study, but technically they're really exactly the same. What you do is you find venous access. I usually use the right internal jugular, and you create an access point, and then a catheter goes out, and it goes out into the right atrium, and you see little A and V waves and X and Y descents, and then it crosses the tricuspid valve, and as it goes into the right ventricle, you get these big pressure waveforms that go up and come down to close to zero. And then if you've got everything lined up just right, it'll float itself out the RV outflow tract into the pulmonary artery. And then when you cross out of the pulmonary artery, two things happen. One, you potentially see that dicrotic notch with closure of the pulmonic valve, and then sort of a flattening of the diastolic component, seeing the capacitance of the pulmonary circulation. You see that's different than here. No notch. And this is a very sharp descent, and this is the blood being trapped from going backwards by the pulmonary valve. And then eventually you'll get out into wedge position where blood flow isn't really happening past this point. Anytime there's cessation of blood flow, there's equalization of pressures. And so this actually should be reflecting the left atrial pressure. And if you measure it during diastole, it should be measuring the left ventricular end diastolic pressure. So this is a left atrial tracing, and this is a right atrial tracing. The reason they're different is this is dampened by the distance between the tip of this catheter and the left atrium. So he had right heart catheterization. The definition of pulmonary arterial hypertension is a mean pulmonary artery pressure of greater than 25 at rest with a normal wedge and a PVR greater than 3 Woods units, or 240 second centimeters to the fifth power, that doesn't fit into other groups. In him, his right atrial pressures were 24, his RV was 75/4, pulmonary artery pressures, his mean was 47, his wedge was 14. We measured by thermodilution his cardiac output and index, and his index is 2.5. Now that we have pressure, flow, we can actually calculate resistance. So when you look at the pressure gradient, mean pulmonary artery pressure to pulmonary capillary wedge pressure, that's the pressure gradient, divided by the cardiac output, 4.86, his pulmonary vascular resistance came out to 586 dyne second centimeter fifth power. If you divide that by 80, you know what the Woods units were. They have moved towards using Woods units in everybody. Our computer just reports out the dynes. So these are now, we now think actually that he is in pulmonary, he has PAH. So just a quick question, which of the following have an elevated pulmonary vascular resistance and normal or nearly so pulmonary capillary wedge pressure? Who group 1, who group 3, who group 4? Who says who group 1? Who says who group 2? Who says who group 4? Who's scared to raise their hand? Why aren't y'all answering? Actually, if you had answered any of them, you were at least partially correct. All of them are exactly the same. All of them have elevated pulmonary vascular resistance and normal, near normal pulmonary capillary wedge pressures. And that's why it's so important to actually have done the workup up front, because the right heart cath isn't going to tell you whether it's 1, 3, or 4, and may not even tell you for sure that whether it's 2 or 1. And so you really got to go through the exercise of seeing, sort of thinking sequentially about the etiologies of it. So vasodilator responsiveness, there you'll see in potentially in opportunities to succeed questions about vasodilator responsiveness. If you take people who have pulmonary arterial hypertension and they are vasodilator responsive, that would tend to predict a better prognosis, and those people will have a sustained benefit with high-dose calcium channel blocker administration. The follow-up really isn't all that long in terms of cohorts of people, and so I'm a skeptic when it comes to treatment using calcium channel blockers. It will help you get the expensive drugs paid for, but if their index is low, they don't require that you do it. How do you do it? You need to use inhaled nitric oxide, epoprostenol, or adenosine. You should not use calcium channel blockers or nitrates because there are systemic effects that you don't want to see. So what counts as vasoresponsiveness? It's a fall in your mean pressure by at least 10 points to less than 40. And fall in mean pressure of 10 points is big. And it can't be because their cardiac output dropped. The reason I tend to avoid this is, first, I don't believe long-term these are disease-modifying drugs. Also, only about 5% of the idiopathic or familials will have vasoreactivity, and basically none of the other people will. So you're testing basically 97.5 people to find 2.5 people, because idiopathic and familial are about half of the cases of PAH. So he fits into group 1. He meets this definition. It's a clinical condition characterized by precapillary pulmonary hypertension with his pulmonary vascular resistance greater than 3 Wood units, and no other evidence of PH from lung disease, CTEPH, or other rare diseases. And you see it's a similar clinical picture and virtually identical pathological changes. So what are those changes? I've always liked this slide. It's a little bit old now. But basically what happens is you have underlying issues such as collagen vascular disease or congenital heart disease that are sort of clinically manifest. And that interacts with some sort of genetic susceptibility that causes this endothelial cell disorder. You see intimal proliferation, the cells actually start to stack up and ultimately create all these different channels in there. And as they get thin, as this lumen gets thinner, you have the hypertrophy of the media. And this is usually associated with low levels of nitric oxide, an alteration in the prostacycline thromboxane balance, and increased expressions of endothelin-1, which is a potent vasoconstrictor. And remember these because these are the targets of what I think are the disease-modifying drugs in pulmonary arterial hypertension. Eventually, the channels get so obstructed that blood slows, you get in situ thrombosis, and this is typically happening right after a bifurcation in a pulmonary arteriole. Ultimately, in stage, it looks like almost like a glomerulus. As you see, these are sort of normal alveolar structures out here, and you have this big massive thing that is actually just, all these are endothelial cells and smooth muscles around it, and you really got loss of the normal channels. So who gets pulmonary arterial hypertension? Like I said, the estimates are, the highest estimates I've ever seen is sort of 50 to 75 per million. It depends on what population you're testing and how they're behaving. Part of it depends on what families live in the community, whether there's one of the big networks of familial or associated hereditary PAH, how many connective tissue disease patients you have, how many people are taking drugs that have amphetamine-like cores that have been associated with the development of PAH, particularly fen-phen, but there's some other drugs out there. St. John's wort is just fun to say. Certain IV drugs, methamphetamine, amphetamine, cocaine have been implicated. The talc that is injected sometimes has been associated with it. Congenital heart disease and HIV also there. In heritable cases, it shows up as autosomal dominant with genetic anticipation. So when you find a family, typically what you'll do is you'll be in a clinic and ask them, so did anybody in your family die of early heart disease? They'll say, well, my mom wasn't all that early. She died when she was 55. And then they'll say, and I'm 25 and I'm short of breath. And oh yeah, 2 of my sibs had sudden cardiac death in our family of 6 kids. And that would make you suspicious that maybe that was a family. Because the severity of the disease is accelerating with each generation, and it's about half of the population, half of the kids are getting it. Half of the cases occur without risk factors. Half of the cases occur secondary to other processes. And most of them, unfortunately, are diagnosed late in their disease because it has this sort of insidious onset. People say, oh, I'm just getting older and a little short of breath because, I'm now 35 and that's a problem. And ultimately, they show up at PAH centers, typically functional class 3 or 4, so shorter breath with sort of minimal exercise. So where in group 1 does our patient fit? You see there are all these subtypes, and he fits in the idiopathic. He doesn't have a family history, and he doesn't have any of the other phenomena. One thing to note for those of you, again, who have opportunities to succeed, they've moved things like sickle cell out to group 5 for a number of different reasons. Pulmonary hypertension in sickle cell patients is very common. It's also usually multifactorial, and administration of pH-specific medications, at least the PDE inhibitors, causes a whole bunch of sickle crises. And so when they did the PDE study in patients with sickle cell disease, they actually had to stop it early because of that. So we think he fits in 1.1. So having decided that this guy has pulmonary arterial hypertension, you got to figure out, okay, so how am I going to treat him? And the first thing you want to know is how bad is it? And this is from the REVEAL registry, which was a drug company paid for registry, but anybody could get in it. It was one of the nice things that drug companies do. And they actually have a longitudinal cohort of PH patients without any biological specimens, but they have a lot of clinical information. They were able to look and see who does poorly. And you see they created several risk categories as a function of how bad their right heart failure is, how fast their symptoms are progressing, are they passing out, which is a really bad sign in PAH and right heart failure, what's their functional class, how far can they walk, what are their BNPs like, what does their RV look like, is it failing, and hemodynamics, do they have evidence of RV failure with a low cardiac output and high right atrial pressures. So you kind of put this together in a composite to figure out sort of what their risk of death in the next 12 months are. Once you kind of know what their risk is, then you can kind of decide. Then you can decide how to start off with medications. I have this cartoon in to remind me the medications are expensive. The PDE inhibitors are typically $30,000 to $40,000 a year. The ERAs are typically $40,000 to $60,000 a year, and the prostanoids are typically $100,000 plus or minus 20 grand on that, depending on doses and which one you do. That said, the medications, when you look at the total cost of treating PAH patients, medications are only responsible for a minority of the cost. Some of these people go on to transplant. Some of these people get repeatedly admitted to the hospital, and so the drugs shouldn't be a barrier to treatment. The cost of drugs shouldn't be a barrier to treatment because they are not the major driving cause. A whole bunch of trials have been done with a variety of different medications. And like I said, there are basically three classes. There are the ERAs, ambrisentan, bosentan, and macitentan. Then there are drugs that actually act on nitric oxide, and sildenafil and tadalafil are the PDE5 inhibitors. And riociguat is a direct stimulator of soluble guanylate cyclase that maybe, if your own nitric oxide synthase is actually depleted and not working real well, riociguat may be a way to kind of get around failure of nitric oxide production in the host. So if somebody is functional class 2, any of these are reasonable. If they're functional class 3, you've got some more things, including the prostanoids, which is the third class of drugs that are out there. And if they're really sick, you need to use prostanoids. You notice the things in yellow, actually morbidity and mortality were the primary endpoint. And ibuprostanol is really the one drug that has the best data to support an impact on mortality. Untreated PAH survival is between 18 and 24 months, and there are people who have been on epoprostenol for more than a decade. And so it seems unlikely to me that medications, or these particular medications, are not disease modifying. So that's the general classes you can do. So now, if you have somebody who is functional class 2 or 3, you've got to decide how best to treat them. Increasingly, there is evidence of initial combination therapy even in the functional class 2 patients. And that would typically be a combination of oral medications that didn't have a ton of toxicity. So either an ERA and a PDE5 inhibitor, or an ERA and riociguat, the direct soluble guanylate cyclase agonist stimulator. And if that doesn't work, then you need to step it up to the prostanoids. This is an arrow just to remind me, if somebody's failing the PDE5 inhibitors, it may be worth flipping them over to the soluble guanylate cyclase stimulant to get around the failure of nitric oxide production. The reason not to go with it up front is it takes a titration. It has a whole lot more problems with systemic hypotension. You can just slap somebody on 40 of tadalafil a day and not really worry about it. It doesn't have a big impact on their systemic pressures at all. They actually have to send a nurse out to monitor what their systemic pressures are as they do a slow titration upward. So as you sit there and ramp up to potentially on triple therapy, if they're still not working, you need to think about sending them out for a lung transplant, or you can do, as a bridge, balloon atrial septostomy, which is just poking a hole and opening up the atrial septum to offload the RV. Now, of course, when you do that, you've created a big extrapulmonary shunt, and so they tend to be pretty hypoxic afterwards because the shunt fraction is pretty large. But really, you're only doing this in preparation for doing lung or heart-lung transplant. That said, the percentage of people who underwent lung transplantation for a diagnosis of PAH has been falling over the last 2 decades. As more and more drugs come on the market and people are actually treated earlier, they tend to stabilize with medical therapy alone. Now, if you can get on top of people after a year, the probability is they will not die of PAH. They will die of other diseases. Some of the people have scleroderma, which has its own long-term mortality challenges, or some of the other diseases that are associated with PAH. So our patient, from a PH perspective, is doing really well. This was his BNP, and you see it went from 3,500 down to sort of nothing. And a 6-minute walk test got up to at least 360 meters. I think that was a slow day for him. The Flolan is the oldest prostanoid that's on the market. It's a little bit annoying to take. You have to kind of carry a pump and have an indwelling line, but most patients incorporate it pretty well into their life. So to summarize, first thing you have to do is make sure you have the right diagnosis. And if you look at my initial evaluations from clinic, you'll see in my history that I'm sitting there going, is this group 4 asking questions about CTEPH? Is this group 3? I'm asking about lung disease and sleep apnea and that kind of stuff. And then ask about group 2, hypertension, metabolic syndrome, orthopnea, P&D, things like that. And then the next paragraph, I'm asking about the risk factors associated with WHO group 2, and then I'll ask about the severity of the disease. What's their functional class? How are they having lower extremity edema? Are they having syncope? And often I'll be able to, just with the history and physical, figure out what is the basis for their elevated PA pressures, put them in a group other than WHO group 1, and often we're able to avoid right heart catheterization. If they have WHO group 1, then you need to go to right heart catheterization. There's no way to avoid it because you need the left atrial pressure and the cardiac output to know what their pulmonary vascular resistance is to make sure that they actually have elevated PVR. Once you've confirmed the diagnosis, then you want to do therapeutics to target pathogenic pathways. I would argue against calcium channel blockers in a substantial minority on that, but there's a lot of other people who tend to agree. Most patients, I think, should be started on combination medications, and there's level 1 evidence to support that. And if that doesn't stabilize them, moving on to IV meds if symptoms progress or you have an inadequate clinical response. So going back to this person, I think you'll see that if we think about that ERS recommended pathway, the next thing we really probably ought to do in a long-term smoker are the PFTs. Certainly not right heart cath, depending on what their Epworth score is. Maybe a sleep study, but only if they have daytime hypoxemia. And ANA, not until you've gotten past the point of the VQ scan. So that's all I have to say. Questions? All right.